Welcome, everybody, to this edition of Lipid Insights. I'm Dr. Alan Brown, past president of the National Lipid Association and clinical professor at Rosalind Franklin School of Medicine and Science in Chicago. And I'm very excited today to be talking with Shannon Christen. She's a registered dietitian, a diabetes care and education specialist, and she helps coordinate the cardiometabolic and the lipid clinic at University of Colorado. I've had the chance to work with Shannon on several different occasions, and I'm really excited to have you here, Shannon. Thanks for joining me.
Thanks for the invitation.
So today we're going to talk about a new therapy for familial chylomicronemia syndrome. And we're very excited that a therapeutic agent has actually become approved by the FDA. There have been several programs over the past few years about familial chylomicronemia in anticipation of therapeutic agents coming to the market. So I'd kind of like to remind everybody about the disorder. It occurs somewhere between 1 in a million to 13 in a million people. The most common genetic defect in these patients, which by the way is an autosomal recessive disorder, is being homozygous for a knockout mutation in the gene for the lipoprotein lipase. So they make dietary chylomicrons, but the chylomicrons can't be cleared from the circulation. And as you all recall, chylomicrons have roughly 10 triglycerides to every cholesterol. So if they are in the circulation, the triglyceride levels are extremely high. And unfortunately, none of our traditional therapies for lowering triglycerides have been effective in these patients. So the only effective therapy, and that's why it's so appropriate to have Shannon with us today, is putting them on a very strict low-fat diet. Now, there are other genes that can also knock out the functioning of lipoprotein lipase, such as lipase factor 1, ApoA5, ApoC2, and GPI-HBP1. And if you are either a double heterozygote, compound heterozygote, or homozygous for any of those genes, you present with the clinical syndrome of familial chylomicronemia syndrome. So Shannon, I'm going to ask you to talk a little bit about these patients and what they go through and the most common morbidities of having triglyceride levels often 2,000 and above.
Yeah, this is a really special population. I have had, probably four in my career that I have had the pleasure to work with. And these patients struggle, to continue to maintain that very low fat diet. And that is, can be extremely daunting and complicated socially and otherwise. The main goal is to try to avoid uh, levels that get them to a risk level of pancreatitis. So we are constantly reiterating those signs and symptoms of pancreatitis and when to seek urgent medical attention. But then we also try to reiterate the utility of this strict meal pattern and offer suggestions on how to navigate that. These patients need support and they need family support and encouragement and cheerleading and tough love. And that's what they get when they come to our clinic.
Yeah, and I think I can echo all of those sentiments. I mean, the patients usually have frequent episodes of acute pancreatitis. I have one patient, I have a total of four patients now that are genetically proven, and one of them was admitted 30 times from the time she was 3 till she was 28 with acute pancreatitis episodes. Another patient could eat a chicken breast, but if she had a chicken leg, she'd be admitted within 24 hours. I'll never forget her parents, who weren't very sophisticated, gave her Chinese food for her birthday, and she got admitted with severe pancreatitis. And that patient was only 13 when those episodes happened. But they also suffer from chronic abdominal pain and so-called brain fog, possibly from the high viscosity of the high triglycerides in their blood. But they're accused of being malingerers, alcoholics. Many of them have had their gallbladders taken out because doctors don't realize what their disease is and think they must have a common bile duct stone. And they often lose their jobs, their spouses, and some of their friends because they can't really go out to parties and eat with everybody else. They have to bring their own food, and they're always uncomfortable. So disappointingly, we put these people on fenofibrate and omega-3s. Omega-3s sometimes actually make them worse because they are fats. Some people tolerate it, but some of these patients actually get pancreatitis when you start the omega-3s. And none of these medicines really are effective in lowering their triglycerides, which is frustrating. And it's particularly frustrating if the doctor is unaware of the diagnosis. And, many of these patients are not blessed to see lipidologists or dietitians who are familiar with the disorder, and they don't get diagnosed. And so, because none of the treatments work, they get accused of not taking their medications. They get frustrated with their physicians, and the physicians often give up on them. So, having a therapy that works is really exciting, I think, for all of us. With that said, I think any therapy is going to be on top of a good diet for these patients because reducing chylomicron formation is so critical. And I have found it's been difficult to find dietitians who actually are familiar with some of the more rare genetic lipid disorders. And that's why I was so excited to meet you, Shannon. I know you worked with our buddy, Dr. Eckel, for a long time too. But I'd really like you to give some insight on the appropriate dietary counseling for these patients. And then I'm going to ask you, what can we do to broaden the knowledge base for dietitians generally across the country?
Yeah, I would say I wasn't familiar with this condition either until I had the luxury to work with Dr. Eckel and Dr. Falco in our lipid clinic. I would say I was extremely fortunate to work with them, and they took the time to train me. Essentially, they were hoping that I would be able to help co-manage their high triglyceride patients. And so they were willing to share resources, information, handouts, articles, whatever. And they gave me the opportunity to ask questions. And we talk about these cases like very openly. I mean, Dr. Falco would draw me a picture if I needed to explain all of this. He still does that in clinic for patients. So, um, I think the biggest thing with these patients is the buy-in to continue on that this is the path for management. And so I think we're always trying to keep patients going. There sometimes becomes a food fear factor for these patients. They're afraid to eat. They're afraid what's going to happen. And so trying to provide them with a number of resources that exist uh, currently. I mean, there's a surprising number of resources out there from the FCS community, and the NLA has great handouts on how to support these patients. We have a dedicated, very low fat diet handout, and I send these to patients pretty regularly. Um, I am the type of person, though, when someone's in crisis, to try to make things very simple for them. And I many times will recommend like a clear liquid, fat-free shake of some kind to try to help facilitate some kind of ease. So that's just one less thing they have to worry about. So these patients have to watch, they have to avoid alcohol. They have to really be mindful of their food. They generally have to be in full control of what they're putting in their body. So they can't easily eat a lot of packaged things or go to a restaurant, go to somebody's home. And vacation is extremely stressful for these patients. They have to plan ahead, and they need nutrition. They need enough protein. They need carbohydrates, but their carbohydrates have to be, complex carbohydrates. Otherwise, their triglycerides get worse. And so we have to be very practical about their situation. So I take the time to get to know the patient and their support. One of the questions I always ask is, what makes it hard for you to do X, whatever that question may be. And I get a lot more information out of patients when you ask that kind of questioning. What's reasonable? That's the question I always ask myself is this reasonable what they're telling me? Is this reasonable what they're able to do or not do? And kind of what can I do to support them, encourage them, cheerlead them? Those are the things. I think as far as increase in knowledge of dietitians, one of the areas that I think we should probably do is one, I would love to see more dietitians in lipid clinics and in cardiology. I want them to be like me. I'm in a clinic where we're all in the same dictation room and I have a multidisciplinary. So I have a PharmD, I have a cardiology based nurse, I have endocrine based providers, I have a cardiologist, and we are together and we discuss cases and we get to ask questions. We feel like a family. And so I think you don't necessarily always get that if you're all in your individual offices. And so I think having dietitians be in the clinic with providers seeing patients, I think is really important to develop that rapport and to be able to gain knowledge, for either you or the patient. I also think the inpatient dietitians are an area that is unexplored because when these patients are admitted to the ICU and are NPO and need nutrition support, these dietitians probably really need to be a part of that conversation, so that they don't accidentally give them a formula that doesn't fit with their FCS, or just to be on the lookout for this condition. I think GI dietitians are also an area that we should probably be working with because these patients have a lot of GI symptoms. Their pancreas is really beat up, so they may have diabetes. So I think diabetes is another area we can tap into. I think there's room to grow for sure.
Yeah, so all of those are great points. Obviously, we got to keep these patients on a really low fat diet, like less than 10% calories from fat, correct?
Yeah.
And then if they do get a little fat, I know we talk about medium chain triglyceride oil, which isn't always the most delicious, but they could use a little bit of that. And then supplementing fat soluble vitamins, right? So how do you counsel people on those things?
So, I tend for the MCT oil, I tend to you don't want to cook it, right? It is a low temperature product. So we utilize it in for like salad dressing, essentially, is how we kind of slow roll that. And they can't buy this from Costco. Okay, needs to be a medical grade product. And we start slow because they can get really bad GI upset if you go too far too fast. We vitamins, we might screen for fat soluble vitamin deficiency just to see where we're at, making sure that we know if we're depleted, we're replacing, and then we kind of follow up to make sure that they're also staying at that adequate level. I think there's more to grow with all of this, and patients many times have advice or thoughts or questions. And so having the open communication with these patients is important so that they feel like comfortable to say, hey, I want to go to Disneyland and what can I do? Or, utilizing some other resources of other experience of other patients. I think having that collaboration is really important. One of the frustrations I had heard recently from an FCS speaker with FCS was that, you know, it's tough. I'm tired of the ideas I have for eating. And so I just briefly said to her, have you leveraged technology in your favor? And she's like, well, what do you mean? I said, have you asked ChatGPT to look at your refrigerator and take a picture and advise you on a recipe? Have you explored some of those options? Have you reached out to the FCS community and asked for, what do you have available for a recipe? I'm tired of what I have. There's a big community for this.
So this is all extremely helpful, and I think even though we're entering a new era now that we actually have a therapeutic agent that works for these patients, the diet is still going to be critical because even if you use an agent that lowers triglycerides pretty significantly, a dietary indiscretion on therapy could theoretically put these patients in harm's way. However, at least in the clinic, the pre-release trials, the sort of pivotal balance trial of patients who had FCS and who received the new therapy, olezarsen, which is called Tryngolza, they had wonderful outcomes. They all maintained their diet. The people who were in the placebo arm had 11 episodes of pancreatitis during the course of the trial, and there was only one episode of pancreatitis in the arm of patients who received active drug. So now the FDA has approved it. The drug is made by Ionis, and there are several things in place to help the patients get access to the medication. So maybe we could talk a little bit about Tryngolza or olezarsen. It's an antisense oligonucleotide, which uh, turns on a RNase to destroy the messenger RNA for ApoC3. Um, as many of you know, ApoC3 inhibits both lipoprotein lipase and hepatic lipase. And when you remove it from the circulation, theoretically, you would remove inhibition from lipoprotein lipase, but these patients don't have functioning lipoprotein lipase. You're just removing inhibition from uh, a lipoprotein lipase that doesn't work. So theoretically, this should not work, but it does. And it's very exciting that it does. And our current thinking is that when you remove ApoC3, you actually express non not the typical receptors, but receptors in the liver that will pick up chylomicrons without them being broken down into remnants. And so that's how the triglyceride levels go down as you increase clearance of chylomicrons in the absence of ApoC3. So that's the theory of how it works. It lowers triglycerides significantly, roughly 50 to 60% in these patients. And again, in the trial, they did maintain a low-fat diet throughout the trial. Um, I wonder, uh, Shannon, if you want to talk a little bit about the safety. I think your site participated as we did in the trial. Um, Issues about safety with the drug.
Yeah, it was a really safe drug as far as the frequency of adverse reactions. I think it's pretty similar to all injectables. It's always site reaction. There was a slight decrease in platelet count, and arthralgia was also listed in that.
Yeah, I think the platelet count, interestingly, never got below 50,000. The earlier version of olezarsen before it was a GalNAc drug called volanesorsen had issues with thrombocytopenia. Um, but once they used the GalNAc version, which I'm sure most of the audience knows, is you attach a sugar residue to the messenger RNA on the oligonucleotide, and then the liver picks it up like a sponge uh, via a receptor on the liver that binds that sugar. And that allows you to drop the dose almost tenfold. So olezarsen is the GalNAc version of the older drug. And with that lower dose, they didn't have any clinically significant thrombocytopenia. And so nobody in the group dropped their platelets below 50,000. And nobody had any bleeding episodes, so that's very encouraging. And I don't believe you're required to follow platelet counts when they're on the drug.
Mhm.
So at the present time, the best way to provide this for your patients is to contact Ionis sales representative. In my humble opinion, you can write for the drug, but they come and help you very much with regard to getting the patient's paperwork in and helping getting approval for the medication and getting them started. So I have utilized that on the patients that I have to get them on treatment. Uh,
We wrote our first script this week, so
uh, yeah, I have three. And then I'm getting calls from other institutions in Chicago. A couple of the universities have called me and asked me if I was aware of the new therapy. And then I've provided them with the name of the rep, or, if they wanted to send the patient to me, they could. But most of them have just, contacted the representative. I even got a referral for one patient who has both FH and FCS. And I didn't get to see that patient. I would have kind of loved to see the patient, but the institution went ahead and took care of it themselves. So, any thoughts, Shannon? Now, you and I have both lost sleep over these patients, and I always say that there are very few lipid patients that keep lipidologists up at night, but these are the patients that do because of their recurrent admissions. And you've tried everything you know to try. And even those who actually follow their diet very closely will occasionally get pancreatitis. And it is variable. Some patients are pretty well controlled, and others, you know, terribly poorly controlled despite their best efforts. So they do keep us up at night. So I'm very excited to be able to offer them a therapy that will hopefully keep them out of the emergency room. I wonder about your thoughts.
yeah, I mean, I'm excited for the estimated triglyceride lowering of about 50% for these folks and the hopes that their rate of pancreatitis events is lowered. And uh, I think, you know, we're going to learn a lot in real world with these medications that are coming our way. And I mean, with the 8%, I think, mortality rate for these patients, I take it very seriously. I probably take it more seriously than the patients do as far as like symptoms of pancreatitis. I feel like that's like my usual spiel with patients. And our clinic does things a little differently as far as screening for new referrals. Like we pre-screen new referrals. Our nurse does that. And if they see any FCS diagnosis or triglycerides over 1,000, she'll alert us and we will try to fast track these patients into earlier appointments. One of the other things we do is I go ahead and call them and get them started on the very low fat diet before they come to see us, to get them kind of on a track. And hopefully then when they arrive to an appointment, we might have them in a safer range.
Yeah, so once again, I think we can close with saying that, this is a disease that for anyone who's seen the patients, uh, we feel terrible for these patients. They struggle. They're amazing. They're heroic in how they're able to get through life and do things for other people, while still, dealing with a situation where they have to be so careful about what they put in their mouth and with all the social issues that we discussed earlier. Uh, so having a therapy for them is very exciting for us and for them. And I think uniformly they're all excited about that. Secondly, we have a new agent that is now FDA approved, Tryngolza or olezarsen. And it'll be very important that you are all aware that it's available. And when you do have these patients, that you don't forget that there is a therapy that should change their plight. The third thing is the importance of them staying on the diet and trying to make sure that someone in your institution is like Shannon and that understands appropriate dietary counseling for these patients. And I'll give you one example of what could be dangerous. Some of these patients have had so many episodes of pancreatitis, they've developed diabetes, but not type 2 diabetes due to insulin resistance, but a diabetes due to lack of insulin because of pancreatic insufficiency. If someone doesn't ask them what came first, the pancreatitis or the diabetes, and puts them on a diabetic diet, which is a higher fat, low carb diet, then that's going to be very dangerous for those patients. They'll actually get worse. So, in your institutions, finding somebody who could be an expert on this and who is going to be doing the counseling for severe hypertriglyceridemia makes a lot of sense. And then the final thing is identifying these patients. Though they're not common, they are out there. And, Shannon has four, I've got four, and several lipidologists around the country that we deal with will tell you they have at least a couple of patients. So they're out there. And making the diagnosis isn't as complicated as you might think. You can do genetic testing, but the clues are that you have a patient who is generally not obese. Their LDL levels are very low if you can measure them. They have persistent high triglycerides and they don't respond to any therapies. And then finally, they don't have any other superimposed disorders that might cause high triglycerides like alcoholism, obesity, or poorly controlled diabetes. So when you see someone who, without those secondary factors, who has refractory hypertriglyceridemia, often starting at a young age with pancreatitis, and they don't respond to therapy, you should think about FCS. And we kind of divide them into three groups. There's a so-called multifactorial hypertriglyceridemia, which are not FCS patients, but patients with a milder genetic abnormality who have, say, uncontrolled diabetes or alcohol. They respond to therapy in general, and they respond to treating the secondary cause. Then you have the clear-cut, genetically proven autosomal recessive patients who have severe hypertriglyceridemia and, for example, homozygous for a lipoprotein lipase mutation. Those are clear-cut familial chylomicronemia syndrome. And then there's a middle group where the genotype may not be classic, but clinically they act just like FCS. They don't respond to therapy. They don't have any other superimposed maladies that could raise their triglycerides. And we call those folks functional FCS. And they also require therapy, obviously, because they have recurrent pancreatitis. So that's a way to think about it. I tend to ask people at meetings, have you ever had a patient that you remember? And you tend to remember them that had triglycerides that were extremely high. They didn't respond to fenofibrate, omega-3s, or any other triglyceride lowering therapy and had recurrent pancreatitis without any superimposed disorders. And that's what you should be thinking about. So, Shannon, I'm going to give you the last word. Any other thoughts? I mean, we definitely are excited about having a new therapeutic agent, but do you have any other concluding thoughts?
Think, you know, the importance of having a registered dietitian and probably a diabetes educator because these 25% of these patients will get diabetes. And so I think teaming up with someone, and if you're unhappy that of the knowledge they have, provide it to them, reach out to them, use your resources. There's an incredible amount of resources to train dietitians up on this rare disorder. NLA has a great amount of information. I even, you know, I don't have all the answers. I don't see kids necessarily. We see families, but not kids. And so I have utilized a resource at the NLA that sees pediatric triglyceride patients, and she was an amazing resource. And I think, being supportive of these patients requires a team effort.
Yeah, I'm so glad you pointed that out. The NLA, and of course, we're a little biased about the NLA, but the NLA has a website, learnyourlipids.com. And if you click on FCS, there's even a cookbook there, but a lot of information. Also, a group of dietitians from the NLA, and I'm thrilled that Shannon is not one of them. They are available to help with counseling. I actually was contacted by a family in Iraq whose sister happens to be one of my patients in Chicago. And there was a 5-year-old in Iraq with FCS. And I was able to get a dietitian from the NLA who's an expert in FCS to get on the Zoom call with me. And we were able to give some counseling to that patient, which was exciting because they didn't have a diagnosis. And I'm hoping that, maybe that family will be able to reach out and get the therapeutic agent. The patient was only 5. But there are plenty of resources. There's also the FCS Foundation, which is a patient-driven group that has a lot of information. So we encourage you to get knowledgeable about this and, share that knowledge with your colleagues. And again, it's a real fantastic development that we now have a therapeutic agent for familial chylomicronemia syndrome. So Shannon, I can't thank you enough for taking time to be here for this podcast and for your wisdom and also for all you do for patients. Thanks for joining us today.
Thank you.
And thanks to the audience for your interest. Um, I remember in my early years when lovastatin came out, I thought, okay, now we've got everything. There'll be nothing interesting in lipidology, but every week we have something to get excited about, and Tringolza is one of those things. So very exciting. And thank you all for your attention.